Hello everyone, my name is Siddharth Balaji, MS3 here at UMKC School of Medicine. I'm going to be discussing my poster entitled Comparing Usage of FDA 510K and Pre-Market Approval Pathways within Orthopedics to Other Specialties to Improve Device Safety. First, I must talk about the two different FDA pathways that are used to evaluate medical devices. We have the Pre-Market Approval, also abbreviated as PMA, requiring clinical trials for approval and supplemental pathways for modification, and 510K requiring only substantial equivalence to existing devices. This is important to know because previous research has showed a higher percentage of orthopedic devices entering the marketplace via the less demanding 510K pathway. This had got to the point where the Institute of Medicine proposed dismantling 510K, considering an associated 2 to 12 times risk of recall. Nevertheless, we hypothesized that the percent of 510K orthopedic devices compares to other specialties when adjusting for PMA supplements. In regards to the PMA pathway, prior research demonstrates that orthopedic devices undergo numerous modifications via PMA supplement pathways, including major modification supplements, also abbreviated as MMS, with little or no clinical testing. Again, in regards to PMA, we hypothesize that use within orthopedics will be comparable or less than other specialties. Now that we have discussed the FDA pathways, this brings me to my aim of this poster, which is to investigate the current FDA safety pathways use within specialties. The first objective that was done during this project is in regards to the QI framework. A3 framework was used to determine the root cause of safety concerns, and this pointed to limited clinical testing. The second objective was data collection via the FDA database. The date range was set to January 1st, 2008 to December 31st, 2017, and PMA and 510K clearance data for orthopedics, cardiovascular, and all remaining specialties, abbreviated ARS, was calculated and compared. Stat analysis was done using Microsoft Excel and SAS version 9.4. The results are present in Table 1. So what does the results in Table 1 show? In regards to 510K, there is not a statistically significant increased use of this pathway in ortho. Its use is comparable to other specialties. No statistically significant differences were seen with the major modification supplement pathway as well. But one concept to know with MMS is that the range was large. The results for PMA can be well visualized using Figure 1. Cardiology had a statistically significant increased use of the PMA pathway, supplements, and supplements per device here than the other specialties. So what conclusions can be drawn from these results? Well, the results reveal that increased 510K use is not isolated to orthopedics. It compares to all fields except cardiology, which uses PMA and PMA supplements more than other studied specialties. The large MMS range was important to note earlier because it supports concerns from authors stating that devices undergo substantial alterations post-approval. This data infers 1. Universal reliance on 510K, since all specialties use this pathway in a comparative manner, and 2. Cardiology's increased use of PMA supplements, and though cardiology has the most number of supplements, there's a presence of MMS in all specialties. It is also important to discuss certain limitations before some final remarks. There may have been errors while extracting data from the FDA database. Nevertheless, this database has been used in previous studies in a successful manner. Additionally, while previous literature has looked at PMA supplements individually, their role in the PMA process with regards to device safety has not been investigated. For instance, do more supplements increase the safety risks of a device, or does the original risk of the device beget more supplements? This distinction is important for future research because it may influence where greater oversight is better placed. In conclusion, I want to reiterate some concepts. First, nearly all novel devices go into clinical use without supporting clinical data, raising broad safety concerns throughout specialties on the effect it has on patients. Second, despite requiring clinical trials for initial approval, high-risk medical devices undergo many modifications over time, often without supporting clinical evidence. The clinical implications of this are unknown, and they require future further investigation to understand the safety implications and the effect it has on patients directly. Thank you everyone for listening to my poster discussion today. I want to give a quick shout out and thanks to Dr. Dubin for being a great mentor throughout this research project. Cheers.